Invite Associate Professor Sathya Rao OAM from Spectrum Victoria to come up on stage to deliver the keynote address on suicide prevention and BPD.
And people who know me as an optimist. So my presentation is going to have that optimistic sort of a tone. Maybe not based on very strong research, but the research that we have done at Spectrum and what we have experienced in the last 25 years. So I'll briefly summarize why I believe suicide in borderline personality disorder is preventable, and the Spectrum's experience and observations in the last 26 years with respect to suicide prevention, and the coronial data in Victoria. We did a large audit a few years ago, and also we audited the ambulance and emergency department data, again all in Victoria, and what can be done towards suicide prevention and stop the 1 in 10. This is Frida Kahlo. Even in the painting, you can see the psychological pain Frida Kahlo has experienced. But people say that she had a diagnosis of borderline personality disorder. This is the basis of my presentation, and I believe that the suicidal behaviors they are rooted in their way of coping. One of our senior colleagues, Joe Paris, famously said that people with borderline personality disorder feel suicidal to survive. Okay, why do I believe suicide is preventable in BPD? That's based on my experience at Spectrum. Now, we looked at, last year I looked at the data, the suicide data for Spectrum. Now, we have treated about 5,000 people with borderline personality disorder over the last 26 years. And we've lost 18 souls for death by suicide, 18 too many. However, when you compare it to the 10% suicide rate in the community, we take some solace in these numbers. Of course, this is while they are with us in treatment. So what we are trying to do is we want to know whether those numbers will hold up after they are separated from the treatment. So we are embarking on a large linkage study to examine the follow-up data. Anecdotally, what we are finding is that our initial observation is that these numbers still hold up. So that gives me enormous amount of confidence to propose and hypothesize that suicide in borderline personality disorder is perhaps preventable. Also, given the fact that when you look at the characteristics of people who are referred to Spectrum, these are people in public mental services, and they are often quite unwell, have complex needs, and who have high suicide risk and significant trauma history. And what we do at Spectrum, as Bren has clearly pointed out, it's not rocket science. What we do is we provide trauma-informed care, we provide compassionate care, and we have psychological treatments. And our clinicians are highly trained, and they have the privilege to do psychological treatments up to 2 years. So we have also tried to understand suicidal behavior of people with personality disorders over a period of 10-15 years. We have struggled with that idea, and we came up with the formulation method of understanding the risk. That is that matrix method, which is there in the picture, and which was sort of noted in the NHMRC clinical practice guidelines. And our chief psychiatrist in Victoria put out a white paper in which he also noted and recognized our risk assessment. We also published a couple of papers showing its usability. So if you look at the global research tells us that most people with persistent suicidalities can get better over a period of time. And this is John Gunderson's study, which shows that over a period of time, suicidal behaviors and self-harm attempts do come down quite significantly. Again, you don't have to do rocket science treatment for this. So what we know is that treatment of borderline personality disorder perhaps is the best risk management we could do for people with borderline personality disorder. So if we are serious about preventing suicide in borderline personality disorder, what we need to do is to offer treatments. Now, with that in mind, we were trying to examine the effectiveness of spectrum treatments in reducing suicidality in borderline personality disorder. My apologies, the formatting of all my slides seems to have gone. I hope you can still see. This is an older paper that we published. We looked at the residential treatment data and 12-month outcome data for spectrum work. It shows that there was a statistically significant reduction in suicide and self-harm behaviors. Then we looked at 18-month follow-up data. Again, there was reduction in self-harm and suicidal behaviors. We did a group intervention that was very intensive. We provided 80 hours of treatment in 10 weeks in groups to see if that would work. And that would be also economically quite viable. Again, we found that suicidal and self-harm behaviors reduced quite significantly. Thank you, Rita. I wouldn't know what I would do without Rita. Thank you, Rita. So that again reduced. So my take is that it doesn't seem to matter what we do at Spectrum. Whatever kind of treatment we do, it seems to work. And it seems to reduce suicidal behaviors and self-harm behaviors. So that gives me enormous confidence to stand in front of all of you and hypothesize that perhaps we can prevent suicide in borderline personality disorder. And I've asked this question several times: why do we have a lower suicide rate compared to the community, or compared to treatments that happen in general public mental systems? I would love to say it is because of the highly specialized treatments that we do, or we have some really high skills and magical ways of doing it. Not true. It is because we just have the privilege to treat people with personality disorders in the way that needs to be treated. Again, it doesn't seem to matter whether we do DBT or MBT or the generalist treatments, common factors approach. It doesn't matter what we do. All of them produce the same results. So again, with this in mind, after having understood a little bit about our own patient population at Spectrum, we embarked on trying to understand what's happening in this state. So what is the suicide rate for people with personality disorders in Victoria? And also, can we identify those people with the personality disorder who are at a risk for death by suicide and offer treatments? So with that in mind, we looked at the coronial data for a 5-year period, thanks to the Victorian Coronal Court. So that data, it was a large audit that showed that 10% of all suicides for all reasons in Victoria was for a diagnosis of personality disorder, whether it was confirmed or suspected. And the next line is the most important one. 99% of them had gone through public mental health in the preceding 1 year. And 88% of them had gone through public mental health 6 weeks before they died. And quarter of them came to emergency departments. So, and they were in contact with clinicians a lot, whether it is general practitioners, psychiatrists, mental health clinicians. So it's not that they're not having access to clinical work. They're having access to clinical work repeatedly. So conclusions from this study was that most people with the diagnosis of personality disorder who die by suicide have access to public mental services. And they've also had lots of contact with mental health clinicians and come to emergency department. I'm repeating again because this is really the point I'm trying to make. So therefore, can we further identify those who may be at a higher risk, even amongst these people, whether could we identify a little more higher risk group and offer some specific treatments? And can we train clinicians to provide appropriate care? So we looked at the ambulance data. So again, it showed really a small number, contrary to the popular belief, only 4.13% of all mental health and AOD presentations wait for a diagnosis of personality disorders. And despite the low prevalence, reattendance was very high. And on an average, when you compare for depression, people with personality disorders utilized ambulance services 8 times, and compared to depression, which was 2.2 times. And of the 4.13% of the people who used the ambulance, of them only 8.3 of them accounted for 50% of the ambulance service. So my feeling is that if we can zero in on these numbers, see, it's not going to be 6,000 people. We really need to do the focus. Even a smaller number, if we focus and provide a treatment, my hypothesis is that suicide should be preventable in borderline personality disorder. And we looked at the emergency department data. Again, a very similar, a small number. Only 1.8% of all ED presentations were for borderline personality disorder. And 73% of them attended repeatedly, more than once. And there was one person accounted for 250 presentations. So again, still that person is not getting the treatment. What more that person needs to do? So given these numbers, so I believe that if we could provide some focused treatment for even a smaller number of people, we should be able to do some good work. So how do we do it? In Victoria, given the 1% prevalence in the population, there are at least about 60,000 people who may have a potential diagnosis of borderline personality disorder. Given that about not more than 10% access, 6,000 people, all the people who die by suicide go through public mental services. This is the point I was trying to make in the panel discussion. So if we could treat them, we should be able to prevent suicide. Again, our colonial study showed that 80% of the suicides were in the adult age group of 18 to 64 years. So what is risk assessment? We discussed in great detail earlier on. Provide treatment for BPD, having a strong, authentic therapeutic relationship. Haley Peckham here is talking about the authenticity of relationship, which is important earlier on. And treating the co-occurring conditions, having a collaborative safety plan, and restricting access to lethal means. I'm talking about medicines. A quarter of the people who attempt suicide seem to utilize the prescribed medications, and there are no medications which are patented or indicated for treatment of personality disorders anyhow. And offering the 24/7 crisis support, which Rita was talking about. We have thought about a model of care for Victoria, using the tiered approach. For most people, a relationship, a psychoeducation may be enough. Could we look at a core competency training framework, which through the BPD Foundation we have tried out with the help of the National Mental Health Commission. We got a grant for a national training project. We developed a core competency training framework based on common factors approach, generalist, good clinical care approach. And beyond that, we could go into more specialized treatments, also bringing the primary sector, public sector, private sector all together. And the Gold Card Clinic, which Bryn developed, which has been shown to be quite effective. And could we adopt those sort of models? And bringing in the lived experience workforce at all levels of care. And Spectrum being the resource center and the last sort of a tier. Some self-promotion from Spectrum. We have published a couple of documents. One is a guideline we have developed guidelines along with 6 mental services, lived experience workforce, and a multidisciplinary team. We developed guidelines for treatment of borderline personality disorder and proposed a model for the Victorian area mental services. And we have done a similar work for the primary sector for the GPs. We have also proposed standards of care, thanks to our Chief Psychiatrist's office who supported us with this launch. So the take-home message is that death by suicide in borderline personality disorder is reduced if people receive psychological treatments. So while in treatments, they don't seem to choose the option of death by suicide. So treatment of BPD doesn't need to be complex, and with time, most people with borderline personality disorder stop wanting to kill themselves. That's the hypothesis, And that's a take-home message I would like to propose. Thank you.